That's brilliant. Thank you.
Thank you.
Thanks, James, and thanks, Maureen. I'm going to talk to you briefly today about this topic, which is dear to my heart in many ways. For those of you who spend any time at the Royal London Museum, you'll often be wandering around with a tracheostomy trolley. So we're going to talk about transferring the tracheostomy. This came up as part of some feedback after the last meeting, but I think it's quite an interesting topic as we get into moving more people who are perhaps in a more chronic phase rather than necessarily those who just come in the door, because it presents some particular challenges. So I'm going to talk briefly about why we might be moving somebody who has a tracheostomy, i.e. why they have it. I'm going to talk briefly about the different insertion methods, but not for any great length of time, just to highlight why the relevant things are important to you. And I'm going to talk a bit about the types of tracheostomy, and particularly if you're going to move somebody, how you might troubleshoot it on the way. So we've been doing this for a long time. In the olden days, it was pretty much for obstruction, but nowadays most people in the world have a tracheostomy put in for essentially facilitation of mechanical ventilation and weaning. Tracheostomy for airway obstruction in modern times is still done, but it's actually far less commonly needed because we're better at ENT surgery. So most people who have a tracheostomy who you might be called to on ITU will still have an upper airway. And that's relevant because that dictates how you might be able to manage any problems. So we still do tracheostomy surgically, and it's roughly about 3/4 to 1/4 in the national figures for COVID. Surgical tracheostomy tends to be done in people who can't have a percutaneous insertion, so they tend to be more difficult anatomically. They may have coagulation problems, but essentially you're trying to do the same thing. You're trying to make some kind of hole between the second and third, or the first and second ring, and you're going to put a tube through it. There are different ways of doing it, all of which are really relevant to this talk, except to say that these people tend to have a more formed tract, and therefore you can potentially, if the tracheostomy gets displaced, be more likely to successfully place it back in the right place if it's surgical, because the hole is usually bigger. That compares somewhat differently to percutaneous tracheostomy, where essentially we use a Seldinger technique usually and a graded dilator to do the same thing. So this time it's done under bronchoscopic guidance, and you put a tube in the front of the neck, again trying to get the needle in the right place, and then using a wire exchange technique. Now, the advantage of this is that you don't need to move them, but the disadvantage is that this tract is significantly less well formed. And so if a tracheostomy is displaced early after a percutaneous approach, your chances of inserting it back through that tract is much less. Now, we talk about I think some of these are particularly relevant when we're moving tracheostomy, that actually there's a lot, it's a really unnatural thing to do to somebody. You bypass all of the protective effects of the upper area potentially, so you don't moisturize as it comes through, you don't humidify it, and you have the effects on the patient, so they can't really smell or taste normally, they can't speak well. And essentially they are an increased risk of infection, both because of aspiration, because they can't cough and clear secretions that will be on part of their airway, but also they can, you bypass the filtration that occurs because of the head. And one of the biggest problems that we have, and I think the biggest problems that we have, not just within transfer, but also within other, is that tracheostomies vary between trusts. So certainly within North East London, there are at least 3 different manufacturers who are used commonly. And the problem is that kit is not interchangeable. It's not easily adaptable between one place and the other. So you do need to be careful and cautious about what bit of kit is in. We're going to go through what I think you should probably need to know before you proceed with the tracheostomy transfer. So apologies to anybody if I'm trying to teach you to suck eggs, but I kind of wanted to go through some of the things that I think you might come across. Different tube types in use. The first 3 are pretty much given, so we don't tend to put high pressure tracheostomy cups in anymore, same way they don't put high pressure ET tubes. And most of the tracheostomies that you're going to come across that we will be moving will be temporary. There are people who have permanent tracheostomies in the community, but they're few and far between, and they're usually not critically ill. The other thing is we don't tend to have what are called dual lumen tracheostomies anything other than dual lumen tracheostomies in hospital. So by this, I mean a tracheostomy that has an inner cannula, and the majority of tracheostomies have an inner cannula because it's safer. If the tracheostomy gets blocked, you can then change the inner cannula, and you don't need to change the whole thing. That differs slightly from single lumen, where the only one that you may commonly see in use is the adjustable flange. They do have a dual lumen version of it, but a lot of this adjustable flange tracheostomies will be single lumen, so they don't have an inner cannula. But we'll talk about the other bits as we go, so cuffed and fenestrated. So the majority of tracheostomies that you will see will be cuffed in adult practice. So by that I mean, like an ET tube, there's a pilot balloon and there's a cuff that allows you to seal off the airway. Now, we've moved quite strongly away from what we call fenestrated tubes, although some institutions will still use them. So the fenestration is essentially a hole at the top, and the idea is you have an inner tube which may or may not have a hole, and you have an outer tube which may or may not have a hole. And if you want to get the patient to speak, you put in a fenestrated or in a tube with a hole, and then the patient will be able to redirect some airflow north. In practice, this never really actually worked. We tend to use one-way valves more frequently now because they're much more effective. And these things also used to get blocked pretty easily. You also have to be careful to know where you are. So for instance, if you have a fenestrated inner tube and you try and positively pressure ventilate, you'll get a leak. So for that reason, most places have moved away from them because you can do things in a separate way. But there are a few hospitals within London that still adopt a practice of putting a non-fenestrated tracheostomy in for a week, and then after a week changing it to a fenestrated tracheostomy to facilitate wheeling. There aren't any in East London. But the other thing is that you can get a bit confused about what's what. So here we've got a cuff tracheostomy tube with a pilot balloon, and then you've got this thing here which is a subglottic suction port. The idea behind this is not to blow air through here, but potentially to be able to suck out any crap that is the risk of aspiration. But again, until you've seen it, you might not know what it is. So this is the transfer talk, and I haven't really talked much about transfers, but I think what we wanted to do is give you some guidance based on what we think, and certainly what I think you should be transferring. So if you're going to transfer a patient with tracheostomy, if you're an uncomplicated tracheostomy played by weaning, we would think that could be transferred in the same way as any other mechanically ventilated patient if they need to be transferred. But if it's a more complicated tracheostomy patient, and this is deliberately not an exhaustive list, I'm thinking about people who've had upper airway surgery, who've had complicated insertions, then that needs a bit more consideration and should be discussed at consultant level about who will be transferring that and when. We would generally expect that those people would be transferred for the same reasons as any other critically ill patient, but we would suggest, and I would strongly push back, that we should do no non-clinical transfers in the first 48 hours after a tracheostomy, be that percutaneous or surgical. Now, we have done this, and we've done this because they were actually the best respiratory patients to transfer, but it's not ideal. Certainly within Bart's Health, the suggestion is that if you read the Trache guidelines, that if you do a non-clinical transfer in the first week, it should be day text. And at the same time, you should avoid clinical transfers at the same time unless it's a kind of life, limb or site threatening, because of the risk, as I say, of the tract not being well formed and displacement. So it's important to try and do these manoeuvres early in the day. What you don't want to do is take a tracheostomy from an area and then perhaps to a less well-staffed area so that you arrive out of hours, because then you don't have the same level of support on the ward, and you may be transferring patients from a critical care area to a ward area that is trache competent, but you may not necessarily know that. So it's the responsibility of the referring consultant to ensure that the patient is going to an area that's capable of looking after a tracheostomy, but it is, I think, something we should specifically check about as the transfer team to make sure that they're expecting us. Every patient with a tracheostomy should have some emergency kit, and tracheostomy transfers without equipment is unsafe, and it doesn't matter the distance. If you're taking someone's CT, you need to take the stuff with them that this patient needs. And as a minimum, I think that should include the following. So you need a dilator to go to reopen the tract. You need to have a spare tube. You need to have one of which is the same size and one of which is one size smaller in case it comes out. You need to have a spare inner tube, and it needs to be non-fenestrated, so that if you have them on a ventilator, you won't get a leak. A syringe in order to inflate the cuff, stitch cutters in order to remove any sutures that may be in place if you have to change it, and then a non-rebreather right-where mask to provide oxygen to the top airway. So if for whatever reason this tracheostomy isn't patent, you know to take it out. Bear in mind that most of these people will be on a ventilator, and we'll talk about that separately. So, we're of the opinion that if you have a laryngectomy patient or a patient with a difficult upper airway with a tracheostomy, or you have a patient who has a single lumen tracheostomy that cannot be changed by the referring site, then that needs special consideration and should be ideally transferred by a senior anaesthetic trainee or a nectar consultant. So difficult upper airway, in my mind, means somebody who has had an awake fibre optic or has required the use of a hyperangulated blade and video laryngoscope in order to successfully intubate. I.e., it could have done it with a Mac blade, but I had to use a VL because, again, we don't have that available to us in the kit. And escorting staff need to be tracheostomy competent. That is not inferred by your specialty or level of seniority, and it's a discussion for us at consultant level to be sure that people who are transferring are happy. And we're all very keen to be approached by this and make sure that no one is put in a position that they're not expecting. I think if you're going to take somebody with a tracheostomy, you need to know a few things. So you need to know why they had it, how they put it in, and that by doing so infers what the patency of the upper airway is. As I said, I would expect most tracheostomies to be dual lumen, but you do need to know if it's single, you need to know the size, and you need to know how often they're being suctioned. A lot of this information is available on the tracheostomy passport. For those of you who are familiar with this, essentially most tracheostomies come with a little sticker that you place in the notes and lets you track the lot number, which has the size and all these things. But although this is a recommendation by the ICS, it's not a universally required within all NHS trusts. Certainly within East London, most trusts do and most hospitals do, but there is not a standardised piece of kit. If you're going to transfer someone, if you're going to sedate them, paralyse them, etc., I really think that depends on the patient. A lot of these patients will be in a weaning phase. They may not require sedation or paralysis, but it is determined by the physiology. It depends on how far you're going. It depends on how familiar and senior the team are. I think it also depends on what the patient wants. They might not want to rattle around awake in the back of an ambulance for 100 miles to Birmingham. There are some minimum monitoring standards, I think we all would agree, and a minimum of 2 working IV accesses. And what I would say as well is for those patients who have COVID-19, they should be transferred on a closed circuit with the cuff up. And by that, that's to reduce aerosolization essentially. So even if they're on trachea mask, we would recommend that they are transferred on a pressure support type mode with an HME filter. You may have seen people with a tracheostomy bib. Those people tend to have laryngectomies and they don't tend to have them over the tracheostomy, but if they do, they should have it taken off because they can inhale it. And you may see people who've got speaking valves or who have something called above cuff vocalization. So if you can't talk, you can actually put oxygen Doppler subglottic and people can get some noise. If you're going to do that, you need to bear in mind that if you're going to take someone awake, they will lose the ability to communicate with you. And so you might need to use something, either an electronic device or kind of hand signals or writing. A lot of people have communication boards to be able to learn to communicate their needs to you during the transfer. I'm going to talk briefly about problems. So I think the first thing to say is if you're worried about obstruction, signs of obstruction would be high pressures, inability to pass a suction catheter, desaturation, and other things. Then you should probably follow the NPSA Tracheostomy UK guidance, which can be pretty much summarised as check the inner tube's not blocked, put it back, put a suction catheter in, check you can. That can't work, let the cuff down. If that doesn't work, take it out and intubate. And if it becomes displaced or is obstructed on transfer, I think the default position is that the ambulance should stop. And regardless of the method of insertion, you should try and reintubate unless contraindicated. I think trying to reinsert a tracheostomy into a stoma at the side of the road is risky because you have the risk of false passage and no one there to help you, whereas we would expect that patients have a patent level there, as I say. Troubleshooting really depends on you figuring out whether you've got one hole or two. Usually there's a bit of a hint, and if it's a big hole, it tends to be a laryngectomy. But often you have these helpful signs at the top of the bed before you come. So green generally means that there is a perforated brain. It means it's been inserted either surgically or percutaneously, but that actually there is still a larynx. And this summarizes these slides. I'm not going to go through them because actually I haven't got time and I better than questions. But if you Google tracheostomy.org.uk, you can go through this, and this essentially is what I've just said. So it's taking off the inner tube, suction catheter, deflating the cuff, and then seeing whether you're pregnant. Laryngectomies tend to be highlighted, and I would also say usually don't have a tube. People who have a laryngectomy may have a tube initially, post-operatively, to facilitate ventilatory weaning in ICU, but then they generally will have that tracheostomy tube taken out within about a week. But they will have a sign that looks a bit more like this, and they are obligate neck breathers. So the difference here is that you will not be able to intubate orally, and so essentially, as I said, they usually won't have a tube, but it's the same kind of thing. If there is a tube in there to facilitate ventilation, it's checking the inner tube, passing the suction catheter, deflating the cuff. But here, if you can't intubate, what you're going to have to do is ventilate the stoma. So you can either do that by turning a normal face mask up by 180 degrees, or you can apply an R-gel to the stoma with a water circuit. It's a bit rapid. I'm aware there's probably going to be a few questions, and so I'll take them there. Stunned silence, which makes me wonder if I was on mute the whole time. Right. Okay. So. Tracheostomy, they're potentially hazardous, and I think they need some special consideration. Always know the anatomy, avoid non-clinical transfers in the first week, and be particularly about what your bailout options are.
Cool, thanks so much, Steve. That was brilliant. If anyone does think of any questions, if they type them, I'm sure things might come up as we go along. That'd be great. There is a chance to revisit stuff after 8 o'clock if anyone wants to stay online, or again, we can answer this at a later date. But I think that was brilliant and certainly answered a lot of the issues raised following last month's case presentation. And I certainly will take a few things into my practice. But